I have chosen today's topic, which is very important for the examination point of the view as well as in the hospital practices. And it is how to interpret X-rays of a diaphyseal fracture, particularly in the examination, and increase the scoring points. So we will see how to go ahead with it. So diaphyseal fractures will be discussing mostly, and these are the fractures which are commonly asked in the examination by externals or the internals in the examination, and especially in the long and the short cases. They will discuss about the clinical findings, and they will put on the x-rays in the view box and then ask the students to read it. We'll see how to go ahead with it. How to describe? First, one must identify the patient on the x-ray. If it is all there, if it's not, then there is no problem. Go ahead with the second part, which is what x-rayed and the side, whether it is on the left side of the bone or the right side of the bone, and which part. And then you have to tell the views, whether it's AP or the lateral. Usually AP lateral views are good enough and usually done in the orthopedics. And then once you recognize the sides and the part x-rayed, you have to identify the fracture, where it is. It is in the diaphysis, is it in the metaphysis or epiphysis, especially the children. If the fracture is in the shaft, which is our topic today, then is to be ascertained where the fracture is in the upper third, middle third, or lower third. We have to ascertain whether the fracture is complete or incomplete. And if the fracture is complete, then we have to look for the following. Surface of the fracture. It could be transverse, oblique, or a spiral. Then we have to ascertain whether it is displaced or undisplaced. And one by one, we'll be seeing all of them. So displacement can be of different types. Just to tell you right now, it could be in the form of translation of the shift. It could be in the form of angulation. It could be in the form of rotation. It could be in the form of overriding, which is also called shortening. And it could be in the form of destruction and sometimes impaction. Then we have to ascertain whether it is comminuted, and if it is comminuted, it means there are more than two fragments. We have to look for a large chunk of the fragment. If there is a large chunk of the fragment, this is usually called butterfly fragment. And then the classification will be according to Winquist type. Then we have to ascertain, especially in the upper third or the lower third of the shaft, if they are fractured, is it intra-articular or extra-articular? Intra-articular means the fracture is involving the articular surface. And in late cases where the fracture has happened a few weeks ago and the X-ray is being seen later, we have to ascertain whether there are signs of union and whether there is soft tissue shadow that will tell us about the soft tissue swelling and whether the fracture is pathological or non-pathological. And if the fracture is complete without any translation or angulation, but there is a shortening, then we have to look for a special type of the fracture which is called impacted fracture or impaction. Some different types of the fractures can be looked in certain cases is avulsion fracture and stress fracture. And in incomplete type of the fractures, we have to look for the buccal fracture or green stick fracture. We'll come to that one by one and describe each of them, how to look and how to describe. So displacement of the fractures usually can be in these types. One is whether it is shifted or displaced transversely. either in the anteroposterior plane or mediolateral plane. It could be tilted, which is also called angulated. It could be rotated, also called twisted, and overlap or overridden is also called shortening. So we can see it here, it is shifted away from the proximal fragment. Also here, the angulated also, here another example of angulation. Rotation, will come to that, how to see the rotation. Usually we will see in the fracture neck of the femur, rotation. And in the fracture clavicle, you can see one fragment is overlapping over the another one, is a typical case of overlapping of the fracture or shortening. Just to tell you what could be the causes of displacement of the fractures, usually due to the force of the trauma that has caused the fracture will displace the fragments, can be due to muscle spasm or sometimes due to gravity. There are some international norms which must be followed, and the international norm one, the X-ray which is being taken, it is usually taken with the part which is fractured or the deceased along with one joint above and one joint below. In children, usually the both sides of the bone is to be taken in an X-ray because bulk of the components are still cartilage. Then we have to see part X-ray side of the views and how to express it. Just one example, how to express this X-ray. So this is AP view of X-rays of left tibia and fibula, including knee and ankle. So this is how you start expressing your X-ray reading. So here again, you can see it here. We will describe, this is the plain X-ray AP view of the right humerus, including shoulder and the elbow. Now we have to ascertain whether fracture is complete or incomplete. We can see incomplete fracture, and here there is complete fracture. And if it is complete, then we have to ascertain whether it is displaced or undisplaced. We can see undisplaced and it is displaced fracture. Again, fracture is complete in the lower end of the radius, but displaced. So undisplaced fracture in both views, AP and lateral view. Here, supracollar fracture of the humerus, undisplaced, but it is a complete fracture. Surface of the fracture is to be seen. It could be transverse, means the fracture line is horizontal. Oblique fracture, the line is angled, and spiral, like a spiral staircase. See the example, transverse, this is oblique, but short oblique when you say, and many say it is long oblique. So this is transverse fracture. Surface of the fracture is transversely placed. Here, it is an oblique fracture. Surface of the fracture is obliquely placed at an angle. And this is a typical example of a spiral fracture, like a spiral staircase. There is a spiral fracture. Again, this is also a spiral fracture. Example of a spiral fracture. So the displacements are translation, angulation, rotation, lengthening or the shortening, and some examples of the displacement, how to express it. So here we can say it here, the displacement here or translation, it is the tibia, the distal fragment is to be seen compared to the proximal fragment where the distal fragment has gone. So here the distal fragment of the tibia has gone towards the fibula, which is placed laterally. So there is a lateral displacement. So AP view tells us lateral and medial, but the lateral view, it is only ventral or dorsal we are seeing it. So this lower end of the fragment, this has gone dorsally. So combined we can say that it is an extra-articular transverse fracture of the distal tibia with dorsolateral. So this is lateral and this dorso. Combine it, dorsolateral displacement. This is angulated. So angulation is seen and described according to the direction where the convexity lies. So convexity is on the lateral side, here also lateral side. So this is the laterally angulated. So angulation and rotation, we will come to how to recognize rotation. So rotation is to be seen according to, again, where the distal fragment is rotated. So we can know it by seeing the width of the cortex or the medullary cavity of the proximal part, also the distal part, both are matching or not. See, it is not matching. This much is the width and here only this much. So it must be rotated because both were very close to each other, must be matching. After the fracture, there is a mismatch. So it is displaced here. After the fracture, the matching is there. So it is not rotated. Here, rotated. So the width changing. You can see again the supracondylar fracture, width here, the proximal fragment and width of the distal fragment is matching. The width of the proximal fragment, they measured it 37 millimeter. So it is quite different from the distal fragment, which is measuring only 19 millimeter. In the hand, the rotation is different. All the nails are directed towards the scaphoid. Any one nail which is directed towards the direction which is other than the scaphoid is rotated. So this is displaced and shortened as well. We will see more examples of shortening. Shortening is there is an overriding of the bones, overriding of both bones, and so this is also called shortening. There can be a case where the fracture ends are driven together. Means the bone substance of each component of the fracture is driven into the other and the pieces are jammed together by the force of the injury. This causes shortening without loss of alignment. So there is no displacement either in the form of translation or angulation or rotation, but there is a shortening, and this case is impaction. So we'll see the impaction, surgical neck of the surgical neck of the humerus, here lower end of the radius, here fracture neck of the femur impacted. So you can see the examples of impaction all through. Can there be a lengthening in the case of the fracture? Yes. If there is a distraction between the two fragments, it will cause increased length, and that is called lengthening. So distraction will cause lengthening and impaction can cause shortening. So there could be a case of compression fracture that we have to recognize sometimes, especially seen in vertebra. So here you can see the height of vertebra. Here it is different. One lower, it is different, and this has been short. So there is a fracture here. There is a fracture. There is a fracture, short height. How to read displacement combination? So there is a displacement combination here. Just try to read it. So there is an oblique fracture, recognizing the sides and then the part X-rayed. We'll come to the description of the fracture. It is an oblique fracture of the mid shaft of the humerus. There is a lateral displacement. There is a shortening and varus angulation. Can see this one, and this is coming like this. Coming like this. This is going like comminuted fracture. If there are more than two fragments, we are seeing more than two fragments, third fragment, fourth fragment, fifth fragment, called comminuted fracture. And if there is a big chunk of the comminuted part, this is called butterfly fragment. So this is comminuted, there is a butterfly fragment. In those categories of the comminution, there could be a situation where there is fracture in the single bone at two levels, so that a segment of the bone is completely isolated and looks like it is floating. This is called segmental fracture. So unusual, there are two segmental fractures in a single bone. Now we have to ascertain, especially in the case of distal or the proximal third of the diaphysis, whether the fracture is extra-articular or intra-articular. Intra-articular means fracture line is extending into the joint, and intra-articular fractures, they usually cause the articular surface to be roughened, irregular, or incongruent. So this is an example of extra-articular fracture. This is supracondylar fracture, fracture base of the first metacarpal, extra-articular. And here an example of intra-articular fractures. The articular surface, if left like this, will become roughened. This articular surface will be roughened, and then it will cause secondary osteoarthritis later on. And then in certain cases where the bone has become weakened by some pathology there, even a trivial trauma can fracture it. So it is a case of the child where there is a bone cyst and the fracture has occurred with a trivial force. The pathological fracture again, cyst present there. Avulsion fracture, sometimes we have to see it. Avulsion fracture is occurring at the site of the tendon insertion. Here, insertion of the tendoachilles, and bone is usually ripped apart by pull of the tendon or the muscle, and it is usually more commonly seen children. Here, the tibial tuberosity has been avulsed. Again, we can see it. The part of the bone where the posterior cruciate ligament is attached over the tibia, that has been avulsed. The consequences will be as bad as the tear of the posterior cruciate. And sometimes patellar fracture can occur by strong pull of the quadriceps muscle. There are stress fractures that we have to ascertain in certain cases. So there are stress fractures that we have to recognize in certain cases. And stress fractures usually are divided in two types. One could be insufficiency fracture and another could be fatigue fracture. Both has to be differentiated. Insufficiency fracture is a type of stress fracture which results from normal stresses on abnormal bone. So here the bone has been become abnormal. The looser zones in the case of osteomalacia are a type of insufficiency fractures. There can be a fracture in the neck of the femur in old age, or in the case of osteoporosis, vertebral fractures, they are the types of insufficiency fractures. And fatigue fracture are usually also called overuse fractures, and it happens due to abnormal stresses on normal bone. Bone is normal, but stress is too much, and it is recognized later on by seeing the cortical thickening or periosteal reaction. So we can see it here. The third metatarsal, there is a periosteal reaction, there is a callus, and later on, after a few weeks, we'll see this type of the condition in that particular patient, and then we say that patient had got a fatigue fracture. This one also, this is here the second metacarpal. You can see the callus. Usually in the first x-rays or just after the injury, don't find any abnormality. There could be a fracture which is also called complicated or uncomplicated. Complicated means fracture is open, means it is communicating with the exterior. And whereas another variety, especially in the children, that if the fracture is incomplete, you have to look for the two types of the incomplete fracture. One is the green stick, another is the torus fracture. The green stick or the torus fracture, both are found in the children. Green stick fracture are the one where one side is broken and other side is only bent. You can see here in the radius, one side it is fractured, one part of the cortex, but other is only bent. So this is typical of the green stick fracture. The torus fracture, also called buccal fracture, again an incomplete fracture, but it creates a buccal of the cortex. Means there is a bulging of the cortex. Torus fracture, also called buccal fracture, is a type of an incomplete fracture which creates a buccal of the cortex or bulging of the cortex. And in the picture, it resembles the bottom of a Greek pillar. So Greek pillar bottom is bulged, and this is how it looks, bulging. This is the bulging of the cortex. This is torus fracture. And this is green stick fracture. One side only bent, side is fractured. Again, torus fracture, it looks like on the X-ray, just a cortical buccal or bulge. In fact, in Latin, the word tori means swelling or protuberance, from where the word the torus has come. And a new type of the fracture has to be added in certain conditions where prosthesis has been given to the patient and there is a fracture due to prosthesis. Usually you can see there is a lucent area or black area in between the cortex and the prosthesis. This black area is the part where it is loose, and by this loosening, there will be a fracture there. The bone has been weakened, and then there will be a loosening. And we must ascertain soft tissue swelling. So here there is a soft tissue swelling. And in late cases where the X-ray has been done after a few weeks or after a few months, we must ascertain the callus formation is there or not, or is there any sign of union. So we can see full union here, fracture site still not breached. Union has taken place. So how to describe the X-rays? Here we can see it, a typical example of the Colles fracture. So this is AP and lateral views of X-rays of the right wrist, and it shows a complete and displaced fracture Colles with following displacement. The displacement is dorsal displacement and angulation. The lateral displacement and angulation, and there is shortening. So this is way describe it. How to describe this X-ray? So this is AP view X-ray of the left tibia and fibula, including ankle. There is complete and displaced fracture of the distal third of the left tibia. Fracture is spiral with varus angulation and lateral translation. So there is an angulation which is varus. So it has gone towards the midline, but the displacement is laterally towards the fibula. And the fracture is extra-articular and there is no convolution. So another example, how to describe these X-rays. So this is the X-rays of left tibia and fibula, AP and lateral views. And there is a complete and displaced fracture of the middle third of shaft of tibia and fibula. So the fracture is complete and there is a displacement. And then details of the fracture is to be defined. The fracture is the transverse fracture. There is lateral displacement. We can see it has gone towards fibula. So there is lateral displacement here. And in the dorsal, here the dorsal displacement in the lateral view. So we can say it, the lateral displacement of both tibia and fibula, there is a shortening and mutate. Thank you very much for watching. Go through the slides a few times to acquire a skill to describe the x-rays of any diaphyseal fractures, and then you will be competent to answer the questions posed by externals and internals. Thank you very much.